Thank you so much, Dr. Poonam. I'm sorry it was too elaborate for you to read through. Well, I think, first of all, I should thank all the previous speakers, and especially, of course, Dr. Shah, Rahul, now Dr. Prabhat, for setting up the context already for me there. My topic has been made easier. So we're talking about, is CGM essential for all insulin users to prevent hypoglycemia in GV? And I completely second Dr. Prabhat that hypoglycemia is one of the topics that is actually underestimated. It is still the iceberg phenomenon. And yes, we can live with hyperglycemia, but hypoglycemia can be fatal, which is something that we should reconsider when we are training our patients. And again, happy to see someone living with diabetes here so that you know that what you're doing is relevant as well. Thank you to be there. So, clinically, if we look at, there's a lot of scientific context and there are a lot of textbooks that talk. But here, what is important is what is clinically relevant when a patient is sitting in front of us. So when we talk about rural areas or when we talk about urban areas, so I do know that my concept here is going to be having an economic impact, but still, what I would like to bring to notice is the best case. So, of course, if we're looking at insulin users, there are four questions that marginally come to me. One, do we need monitoring? Then, why do we need monitoring? Then, of course, what mode of monitoring is best? We know SMBG and all those modes, and of course A1C and then CGM. And finally, is this really going to make a help into my clinical management or in my own control? So if we look at, do we need monitoring? Yes, we know the India statistics. I will not get into the numbers because it's a short debate. So I'll just say that, yes, there is a lot of poor monitoring frequency responsible for the lack of glucose control prevalent in the patients of course. Of course, sometimes it is clinical inertia based on the practicing physician also. So my suggestion, do not assume whether the patient sitting in front of you will be able to afford or not. Important is you offer. Rest depends on the patient. Of course, we say, why do we need monitoring? So we know that there is a lot of data that says that even when we had A1C, which is the gold standard, which is known as the gold standard, of course, you also heard that A1C is not going to give you the whole picture. But if you look at time in range, which is the new metric that comes up from CGM, clearly there's association between these two, and it is shown that time in range is giving us more actionable information than A1C alone. I'm not talking about economics yet. Let's talk about what mode of monitoring is best. Not going to say, oh, stop SMBG, stop A1C, stop this, stop that. No, there is space for everything. Important is you're going to eat proteins, you're going to eat fiber, you're going to eat carbohydrates as well, right? Are we going to stop carbohydrates just because it raises glucose? No. Same way, CGM is also something that is going to complement the SMBG as well as the A1C. Because look at SMBG, and I like the comment which Dr. Shah made in his presentation that when there is hypoglycemia unawareness, it's difficult for you to expect the patient to sit and do SMBG. Imagine the practicality at that point. It doesn't matter if it's a senior citizen or a child. And we're talking insulin users, which obviously means that these are later stages of diabetes. In India, even if you have the best clinic, best facility, patients at 30, 40 years will not want to adopt insulin at that point in time. So SMBG, definitely not an option. A1C will not help you recognize the hypoglycemias. Of course, unawareness also comes into picture. So this is where CGM comes in very handy. Of course, yes, if we look at the data, what is it that the TIR is going to help us? The TIR is definitely going to also help us show impact on reducing the diabetes complications, whether it is microvascular or whether it is macrovascular as well. I'm not getting into the statistics, but yes, we're trying to look here that if it is insulin users, what are the guidelines talking about? Guidelines are clearly recommending CGM in these kind of patients, whether it is type 1 or type 2 as well. So I'll just show you a few guidelines. This is the Asia Pacific consensus recommendations. We have an Indian representation here, Dr. V. Mohan sir. Then we also have the Indian consensus of guidelines, where we have Dr. Manoj Chawla, Dr. Vanshi Sabu, and the list goes on. And we have this specifically talks about that, yes, in type 2, with insulin, definitely yes, very strong recommendation for CGM. In fact, even for oral drugs, there is good scope to use as per treating physicians' recognition. At it, they also talk about, there's another publication which talks about TIR use in different populations. So, it is kind of varied usage. You can use it in pregnancy with insulin, you can use it in type 1s, you can use it in type 2s, you can use it in elderlies as well, because obviously titrations are going to be key in this patient setup. course, there are other publications where they also talk about frequency of how frequently should they do CGM. So basically, what we're trying to do is we're trying to say that where we're looking at A1C goals, yes, do ensure that as per the patient's pocket, recommend them the CGM and the basic frequency and allow them to know about this. Because a lot of times in my practice, I've seen patients come to me and said, "Oh, I never knew about this. I've been living with diabetes for so many years. I never heard about CGM." So just offer the CGM to them. They may choose whether they afford or not basis their pockets. And of course, now we come into the basic fact or the relevant fact. Is this really going to be helpful or not? What is the whole factor behind it? So if you look at evidence, clearly evidence says that using CGM, one can improve the glucose control in both type 1s as well as type 2s. I'm talking about insulin as well as non-insulin users here. So there are two studies, basically impact and replace, where it is shown that not only can we reduce A1C, we can also reduce hypoglycemia. And clearly, I'm standing here in a session of hypoglycemia, where we're talking about how can we improve not having hypoglycemia in patients. So I think CGM is the key to ensuring that you understand the pattern and the behavior. Not necessarily the patient has to have CGM in life. That is not the purpose. The purpose is to understand how the patient's sugar behaves. And if you're using the personal version, we have patients who come up to us and say that, "Oh my God, I understand my diabetes now much better thanks to the CGM," because now their myths are taken care of. For example, there are a lot of patients who feel, "Oh, I used to eat rice, that's why my sugar was high." But now, on the contrary, they realize it's not the rice, it's the portion control that helps. And this kind of myths can be busted using CGM. Otherwise, it's the patient. If you keep telling them, you will be telling them on deaf ears. They may not want to listen because they don't understand. It's not their fault. So CGM helps you to empower them and educate them about this fact as well. So clearly, giving some time is that, when we are looking at CGM, it's not only going to help us reduce the A1C, it is going to help us improving the overall glycemic control. We also heard that there are glycemic fluctuations. Now, obviously, insulin is bringing in glycemic fluctuations. So that will be brought to light. So you'll be able to titrate the doses accordingly. You'll be able to tell them about the snacking or not snacking requirements accordingly. Nocturnal as well as daytime hypoglycemia statistics clearly seen 48 to 40% reductions in these, which is very, very significant. Of course, what does this all bring up? It's improved quality of life. I don't think that there's anything else better than this that we can offer to the patient when we improve the way that they are living, even though they have diabetes. So the new wholesome matrix, clearly there is the time in range, which is not only in insulin users, whether it is pandemic, whether it's optimizing the OADs, it is optimizing the doses of insulin, it is in patients with pregnancy, gestational diabetes, for diet and lifestyle changes, and also excellent tool for hospital. Sometimes it's a completely different new matrix. So now, just to give you a little different concept and perspective to end my talk, is, when we look at smartphones, it is essential to understand that we do not limit ourselves to, just having a particular corporate sector. We also have the rural people now using smartphones. And it is not the same with that, but also with laptops and internets. We are not restricted to having this only in the urban areas. We have people using internet and laptops even for farmers, even for economics, for banking, and various other purposes, and small setups like MSMEs as well. And finally, digital payment. I think I don't need to talk here. India tops the charts here as well, and I think Modi sir is very proud about the same, that when we come to the digital payment, even a Pani Puri fellow has a digital payment option today, which, is a proud thing to feel that India continues to top digital payment charts. So what I'm trying to bring out by all these things is that, we are adopting technology everywhere when it comes to smartphones, when it comes to laptop, internet, and then of course the digital payment as well. So why are we thinking about not adopting the technology, which is going to be a game changer for the patient sitting right in front of you? Let's not make the decision for them as of yet. So, of course, when it comes to insulin, now again, taking bits and pieces from all the doctors, my previous speakers, that, insulin is there, that there's going to be hypoglycemia. There is insulin, there's going to be fluctuations. There is insulin, there's going to be snacking, which can be over defensive snacking because of the potential fear of hypoglycemia. Similarly, you know that there is going to be a lot of times under and overdosing. Oh my God, I ate less. Let me take less insulin. Oh my God, I ate too much. Let me take more insulin. This all can be taken care of if the person understands their own diabetes using the CGM at least once in the tenure of a year. And of course, weight gain is something that we are not even talking about. There was a paper where Dr. Morgan published long ago saying that with CGM, you can not only optimize the insulin dosages, but you can actually bring down the weight gain because you are optimizing insulin, and insulin obviously is known as anabolic hormone. So, in short, for CGM, it is not only that it is giving you a time in range metric, which is going to help the patients have a realistic goal because they are spending more than 70%, which is equivalent to more than approximately 16 hours or 17 hours of time of within their 24 hours time frame within good control. They can be educated and empowered to understand what is good sugar, what is the level that I need to be in, what kind of foods I can eat, what kind of foods are helping me, what kind of foods are not good for me, so good and bad. And similarly, how is the portion control that is going to be helping me? How can I, use my exercise accordingly? How can I time my tablets or medicines accordingly or a physical activity accordingly? And by this, the patient can take care of not only hyperglycemia, hypoglycemia, glycemic variability, but also have well informed actions and thereby improved quality of life. So basically, with CGM, these are the patient perspectives. And for the doctor, obviously, you can make dietary interventions, you can make therapeutic interventions and behavioral interventions as well for the patient. So, is CGM essential for all insulin users to prevent hypoglycemia and glycemic variability? For me, it's a big yes.
Thank you, ma'am. And before starting, I have a disclaimer that my slides will be bland as my face is. So it will be not very catchy and very shaky as ma'am's slide was. So we are discussing about, is CGM essential for all insulin users to prevent hypoglycemia? So if this is correct, I would just have an opening statement that yes, while CGM is often promoted as a breakthrough in diabetes management, as ma'am had said, and even my previous speakers have advocated for it, and I am not saying no, but it is universally not beneficial for especially all patients on insulin. So we have got varied patients on insulin, means we have got basal plus people, we have got basal insulin plus OHA, then we have got basal bolus. So we have to take care of the high cost. Like ma'am had said that she is not talking about the economical factor. But when staying in India, when practicing in a private setup, you are to take care of the economy also. Whenever you see a patient, whenever the patient comes and enters in your clinic, everything has to be assessed. As a physician, we had been taught that the moment patient enters, you have to read the patient profile, you have to read the patient's face, and many things you have to read the moment the patient enters. So the high cost. Then we have the questionable accuracy. We'll be discussing it in the further slides. Then we have the patient discomfort. Then there are the limited clinical benefits. Yes, I do agree that yes, in some patients there is hypoglycemia unawareness, and we are not able to diagnose hypoglycemia. But when we are talking about all patients of insulin, then this role of CGM is questionable. Then it is not a blanket treatment. So we cannot say that CGM should be the standard care of treatment for all the population or all the people of hypoglycemia. So we'll try to take it one by one. So for the cost and affordability, just to refresh your knowledge, like we have got two types of CGMs. One is the real-time CGM, which we are to get in India, means though we are getting it from outside at present, but sooner we'll be getting it in India also. And then we have the intermittent or what we call it as the flash CGM. So for the flash CGM, you have to use your smartphone and then scan, and then only you will be able to know the glucose values. And in the real time CGMs, you have those alarms that you can set those hypo and hyper alarms, and your phone will give you the alarms. So these CGM devices, I don't know about the cost. If you all know, they're quite expensive. It includes the sensor, transmitter, and the receivers. So if you have the smartphone, okay, the reader cost is gone, but the sensor cost, the receiver cost, and the data transmission. So these things are questionable according to the cost. Then when in India nowadays, the population which we cater in the type 1 or type 2 cities, they are usually insurance covered. So the insurance still doesn't cover the CGMs, whether it is in IPD or the OPD. The insurance people, they don't cover the CGMs, not even CGHS, not even other government beneficiary services. They don't cover the CGMs, and even those patients who are in intensive insulin therapy, that also is not covered. So out of pocket experience, these expenses, they are a significant burden to the population, and this has to be taken care of when we are treating our patients, whether it is the IPD or the OPD. Now we talk about certain association guidelines, which I would like to reframe them, though we have studied, Dr. Ritu had already said. According to the ADA, it is seen that CGM readings are not always accurate. So when we talk about the accuracy, what we in our hospital setup, we put the CGM to certain class of patients, and we ask our staff, ये जब कैलकुलेट करो तो 20% 100 के नीचे और 20% 300 के ऊपर का जो भी शुगर हो ना, उसको 20% से थोड़ा देख लिया करो. And we always have to cross check by a point of care device, or what we call it as a glucometer. So that is the minimum thing which we require to cross check this. So on the accuracy part also, we are in the minus side. So this leads to a potential error in the insulin dosing. What my previous speaker said, that we can judge the insulin dosing. Yes, we can get an idea, but we don't get a certain idea that this much insulin has to be decreased, this much insulin has to be increased. Then we had already discussed about the sensor lag. Dr. Rahul had already told the sensor lag which was there in his slide, that he had shown that the patient is showing 100 in the CGM, but when we do the point of care treatment, it was 79 and the patient was showing signs of hypoglycemia. So the judgment only on the basis of CGM is not perfect because of the sensor lag, because it measures the interstitial fluid and the point of care treatment will be measuring the capillary fluid. So it leads to the improper therapeutic decisions. Then these variabilities in the accuracies, they are different in different brands. Like, I don't want to name any brand, but one is from the Chinese company and one is from the European company. We had put a CGM of the European company on one hand and the real-time CGM of a Chinese company in one hand on the same patient, and we had got two different reports. So it all depends on where you have placed the sensor, then which brand you are using. So you cannot rely on a particular CGM for all these things. I don't know about the RT CGM, in the real-time CGM, when it comes in market freely, then maybe we'll be having a different reading, and then maybe next year we'll be discussing about it. Then there are certain patients whom the CGM is very uncomfortable. Means if we recall in our OPDs, many of the patients, they say, Doctor साहब ये तो बहुत irritation हो रही है, रात को खुजली उजली होती है, आप तो हटवा दो साहब. Even a day after, means because of the glue, the sticking, this is pretty uncomfortable and irritating. The skin reactions, allergies, the infection at the sensor site, they are quite common. And the adherence may be poor because of the psychological burden. डॉक्टर पता नहीं क्या लगा दिया, जब मैं मशीन में से गुजरता हूँ ना तो टू 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 बोलती है मशीन. So these are the things. Means we have got patients who are frequent flyers. So whenever they cross the metal detectors, they have the beeps. And in the real-time CGMs, there is a continuous data which overwhelms the patients. It is just like, means when you ask for the patient's experience, they say, डॉक्टर साहब ऐसा लगता है रात में सोते सोते ना बस बीप ही बीप बज रही होती हैं, and they are the fake beeps. So this continuous data, this leads to the unnecessary anxiety of the patient, like at present which I am feeling. So it requires a proper training. Means you are to train your patients, like Dr. Prabhat said, that if you don't have time to discuss with your patient, then don't use all these things. Many times you are not able to discuss all these things with the patient. There are many hidden things which you are not able to discuss. Then there is a risk of overcorrection, like I said, that whenever you get these short-term fluctuations are there and these overcorrections are there. Sometimes the CGM may show 60, but the real means when you take the point of care, it is 100. Just because he has just taken the food, the capillary is showing good glucose, but the CGM is again showing the delayed data. So there are very many technological limitations also, like there may be sensor failure, the calibration requirement is there, then we are to always be dependent on the smartphones. And what ma'am was talking about, Modi ji's idea was very good. But we still need a digital literacy. We still lack the digital literacy in more than 70% of our urban population, not to talk about the rural population. So it is a barrier for many of the patients. Then the most important, like everybody's battery is now declining. So the battery life of the device and maintenance, that is also complex. And if we see the studies, there were studies from Europe and there were studies from Belgium also, in which the CGM was applied to the type 1 diabetes, because there the care is taken care of by the state. So in those patients also, it was seen that the hypo and hyper alarms, they did not benefit the care of the patient, and the insulin and the ultimate control of the patients, that was not changed. So not all patients, they experience the improved in the HbA1c or the glycemic variability. This was a study in 2022. Just because of the lack of time, I was not able to prepare that slide. And then we were talking about the psychological and the behavioral impact. Every time the patient sees, "Arey doctor sahab, no, you should dekhe, dobara dekhe." So this is the anxiety practically which we see in our OPDs. While standing in your OPD outside, he'll just, every time you just see in your CCTV camera, every time the CGM users, they'll be just tracking their sugars. So this is known as the CGM fatigue. Many a times you find the patients who are having a CGM fatigue, and that's why there is a discontinuation. Means we had a protocol that we applied to all the GDM patients. We have a protocol that we should be applying to all the pregnant females with diabetes and the GDM patients, just because for them getting a glucose by capillary is very new and very odd, or बहुत pain होता है. So we apply that. And then also we find the fatigue and the overwhelming situation and anxiety. And lag I've already talked about, and Dr. Dr. Rahul has also told that it is a 5 to 15 minutes lag, and then are rapid glucose fluctuations. So this inaccuracy, it leads to the underestimation or the overestimation of the glucose levels, and there are variability in the different physiological conditions. So if a patient is dehydrated because of maybe diarrhea or vomiting, then there can be alteration in the interstitial fluid composition. Though shock we don't encounter regularly, but in patients of IPDs, there may be shock or poor circulation, so CGM becomes less reliable. And like I said, that for all hypoglycemias, all the CGM systems or all the CGM companies, they strongly recommend that there has to be a point of care or the finger stick verification, and you don't have to rely only on the CGM for the hypoglycemia correction. So then what is the use of this? It is just to see the trends. So this is the RSSDI guidelines, and according to the RSSDI guidelines, it has been shown that the CGM, it should be used only in patients who are on intensive insulin therapy, and just to read the trends of that. And it remains the SMBG will always remain a practical and effective tool to many patients in managing their blood glucose levels. And if we talk about the data interpretation, the effective use of the CGM, it requires proper patient education and interpret the data accurately. So without the accurate training, without the adequate interpretation, it is a potential mismanagement of the condition. So I'll close my statement saying that while CGM has a place in diabetes management, it is not the universal solution for all patients, particularly those with type 2 diabetes with basal insulins. And the evidence supporting its routine use in this population is very limited, with only marginal improvements in HbA1c, and it has got no reduction in the long-term complications. Furthermore, the CGM presents several challenges like the cost, the accessibility issues, more so the accuracy concerns, and the potential for the patient's anxiety due to the data overload. And in many cases, the structured self-monitoring of blood glucose combined with the proper education and lifestyle modification, it provides the similar benefits at a fraction of the cost. So, and I say that diabetes care, it should be personalized, evidence-based, and resource-conscious. And for many patients, CGM simply does not meet the standard. So I rest my talk here.
So first of all, thanks to all the speakers for a nice presentation. My job is to tell about the closing remarks. So regarding the hypoglycemia interest group, first of all, I like to thank Dr. Banchi Sabu for giving us this opportunity and making this group very active. As a chairman of this particular group, we did various activities in the past year or so, and future also we are going to plan so many activities. So our main purpose of doing this is do the paper presentations in various conferences, because hypoglycemia is one of the field which is quite neglected. I'm sure most of the time it is about talk about SGLT2 inhibitors, DPP4 inhibitors, GLP1RA. We do those things and it attracts crowd. But hypoglycemia is one thing we feel that it is not taken care. But we feel the hypoglycemia and then we know how it is how difficult to have the symptoms of hypoglycemia. As a diabetes, as one of the speakers said, treating, as Prabhat said, treating hyperglycemia is a different issue, but treating hypoglycemia, to avoiding a patient going in for hypoglycemia is of prime importance. So, as a group, we have many abstracts presented in various forums and in Diabetes India as well. We have many abstracts. I think tomorrow you can all visit the poster section. We have a few oral presentations as well. And most important thing in our group is we have created an awareness programs pan India. Pan India means the sense all over all state across all states. We did a program highlighting about the awareness of hypoglycemia in the local languages. So that is most important. That is for the public, and it was a well attended webinars, and we did many Facebook live programs as well. So where creating hypoglycemia awareness is very important. The treating is a different aspect, but identifying and educating the patient how to identify the symptoms of hypoglycemia was our prime importance. And regional languages, because many of the times in Kerala or in Northeast or whatever it is, addressing in a general terms may not be feasible. They may not be understandable to the local public. So we made it sure that we involve the local groups, local our colleagues, and made sure that it has been done in local languages and it has been appreciated widely. And another thing is we did a series of webinars where we did a case-based discussion. So today we had so much of talks. All our speakers did a wonderful job. In the same scenario, we did a case-based individual case. Any persons having an any doctors, any treating doctors had an interesting case of hypoglycemia presentation. We did it, and it was widely appreciated. Most important in this last month, last webinar of 2024 was by our group, that is diabetes and hypoglycemia group, where Dr. Simon Eller, who is a pioneer in the field of hypoglycemia from UK, they presented a wonderful topic on hypoglycemia. It was 1 hour session, but extended up to 1.5 hours. We are happy to say that nearly webinar, that is 3,451 registration was there, and 2,066 login was there. So that was widely appreciated across things because so much of interaction was there. We were forced to close the webinar because of the time frame, because it is the night 9:30, 9:45. So, so future collaboration is like international collaboration. But Dr. Banshi Sabu's dream is to because make this group, because hypoglycemia is one of the field which has to be taken care very well. And in an international collaboration, we are in talking in terms with Dr. Simon Heller, so that we can do further researches or further studies for this particular subject. And hopefully by next year, like as our group members, many of us are doing individual studies. We want more studies about this particular subject in medical colleges, in private setups. We are planning to do this hypoglycemia awareness program. So I would like to thank once again the Diabetes India team group, especially Dr. Banshi Sabu, for making our group more active, more interactive. And once again, thanks for the opportunity. Thank you one and all.